Good afternoon, everyone, and welcome to the National Action Alliance for Patient and Workforce Safety webinar, Using Data for Real-Time Learning, Reporting, and Review. We're really excited to have you with us for what's going to be a great call. My name is Jade Purdue-Pulley, and I'm joined by my colleague, Melissa Bodniger, who will be facilitating this webinar today. Melissa, if I could have the next slide, please. Great. Just a few housekeeping instructions. We are recording this webinar. That's the cue to begin recording on that. And slides will be available for viewing. You must go to the National Action Alliance website, which is linked here. Post-webinar, please give us about a week to have those materials made available. And you can also see other tools and resources that are available for your use while you're there. We kindly request that you keep your microphones on mute, and please do not place the call on hold. The system that we're using is not very high tech, and we don't want there to be interruptions either to the call that you must take or to the webinar. But we would love to hear from you and would like your active engagement. So we invite you to use the chat function and ask questions of speakers throughout the webinar. Both our guest speakers and Melissa and I will be monitoring the chat. Also, closed captioning is available, and below are instructions on how you can obtain the closed captioning. Excuse me. Next slide, please. First and foremost, I just want to thank you for your commitment to advance patient and workforce safety. Today, we have about 400 people who had pre-registered for this call, and we hope that all 400 and then some will be able to join in. So first of all, thank you for being here, at least here on the East Coast, where it's been a brutal winter. We have one of our first spring-like days, so I know it's a real choice for each and every one of you, how you're going to spend your afternoons. We hope to make this next hour for you very meaningful. And importantly, that you walk away with things that you can take back to your practice. We want you to learn something new, and certainly please contribute in the chat function with things that you are already doing that are working well. Next slide, please. A little bit of background on the National Action Alliance for Patient and Workforce Safety, should you not be familiar. This is a cross-federal and private organization, full court press to make safe care everywhere, zero preventable harm for all. And it's based upon 5 overarching goals: advancing organizational safety strategy using safety self-assessments. So if that's something that you have not done in a while, we would like to promote that. It's a really good opportunity to assess where you are as it relates to patient and workforce safety. And there are some great tools that are already available, like the safety self-assessment that was developed by the Institute for Healthcare Improvement and the National Steering Committee for Patient Safety. So that's just one of many. But it is a great way to get started and to kind of assess where you are. The next goal is empowering the patient's voice in the safety strategy. And through the development of the National Action Alliance, we've really worked hard to ensure that the patient's voice is at every aspect of this work. And we hope that you are doing the same. Having a patient not only in the room, but contributing to how healthcare delivery is delivered is a game changer, not only for safety, but for patient satisfaction. Both elements very important to our collective work. And third, supporting healthcare workforce by making healthcare safer by design. We know that many of the issues that have been identified through patient safety are systems level issues. And so one of our goals is to identify those underlying areas that can be repaired through a systems process, and that ultimately make healthcare safer for all. Fourth, supporting the healthcare workforce by strengthening safety competencies. Since the pandemic, we know there's been a lot of turnover in our healthcare workforce, and wonderful news, many new practitioners coming online. And so we want to ensure that everyone has this patient safety background and is always thinking safety. And then finally, facilitating learning and research network, which you are part of today. Next slide, please. One of the things that we completed just at the end of last year was a best practices evaluation of high-performing healthcare systems. So these are organizations that not only have a hospital that is achieving high performance in safety, but may have multiple hospitals or hospitals and other types of facilities. And the Agency for Healthcare Research and Quality utilized available public-facing data to identify 3 high-performing healthcare systems and had the good fortune to be able to go on site and call those best practices for sharing with you, with an attempt to spread that nationwide. And this webinar is part of that overall report and the final change package that was delivered. For those that may not be familiar, a change package is simply a menu of strategies, change concepts, and specific actionable items that anyone, regardless of where they are in healthcare delivery, can pick up and begin to test through their quality improvement activities. And so this is available to you, and it is, again, on the National Action Alliance website, which is embedded in the AHRQ website. Next slide, please. So for today, we have just a couple of questions to run on, or the things that we hope that you will get out of the call today. Just ask that you listen in a way for things that excite you from these high performers, what's most exciting, things that you might want to take back to your teams, and then one or two actionable takeaways from presenters today. We will be circling back on a couple of these questions and hope that you will enter your responses to them in the chat. Next question. Next slide. Well, I am absolutely delighted to introduce you to our speakers for today. Both of these folks are incredible and are from the high-performing healthcare systems that we visited in the fall, namely the Mayo Clinic and St. Luke's University Health Network. Of note is that the third healthcare system that we visited was Methodist in Texas, Houston Methodist, and they were unable to be with us today. But first, let me introduce you to Kate Nesbitt. Kate serves as the administrator for patient safety at the Mayo Clinic, and since joining the organization in 2001, she's dedicated her career to advancing safety, quality, and risk initiatives. Kate holds a Master's of Industrial Safety, Environmental Health and Safety from the University of Minnesota Duluth, and a Healthcare MBA from the University of St. Thomas. We're also joined by Chip Harrison. Chip serves as the Senior Network Director and Clinical Risk Management and Network Patient Safety Officer for St. Luke's University Health Network in Bethlehem, PA. Mr. Harrison began his patient safety role in 2007, and prior to that time, he held various positions in his tenure at St. Luke's, including the emergency department as a staff RN and quality coordinator. In addition to overseeing the network's clinical risk management program, Mr. Harrison also shares responsibility for the implementation of the network's quality and patient safety plan and continued development of quality staff. In his current position, he has implemented strategies to enhance the culture of safety and reduce the number of serious patient harm events within the St. Luke's organization. Mr. Harrison holds a Bachelor of Science degree in nursing from Cedar Crest College in Allentown, PA. So please join me in welcoming both Kate and Chip to the call today. Thank you all. Next slide, please. So Kate, with that, I'd like to turn things over to you, and the floor is yours.
All right. Thanks so much for the introduction, Jade, and thanks for the opportunity to present today and spend a little time talking with all of you about how we're using patient safety data at the Mayo Clinic. You can go to the next slide. This first slide here is actually right out of the change package that Jade was mentioning in their introduction. And specifically, I'll be talking about that middle strategy when I look at secondary drivers, and then the change concepts around supporting robust safety event reporting and review, and then leveraging that data to drive decision-making for safety. So if you look at the bullet points on the bottom there, we'll just briefly touch on how we use our dashboards to track our data and our progress at Mayo, how we use them both internally and externally, and establish some of those standards, which is part of the best practices. And then how we also look at real-time data, share data transparently to affect our clinical decision-making, and then using it to support our structured quality improvement efforts. So you can go to the next slide. All right. And before I start, I'll just give a quick overview of the Mayo organization for those of you that aren't familiar, because it kind of sets up how we share our data and the different levels that we'll talk about. If you're not familiar, your Mayo Clinic Rochester is our main campus. It was the original Mayo Clinic, and it's by far our largest campus. Then we have two also larger campuses in Arizona and Florida, and together we call those three the destination medical centers. So the centers that are dedicated more towards the serious and complex care. And then in addition, in the Midwest, in both Minnesota and Wisconsin, we've got 16 smaller hospitals and 40-some clinics that are really focused more on community medicine and primary care, rural health care for some of the smaller sites. And that's collectively called the Mayo Clinic Health System. When you put all four together of those entities, we refer to it as the enterprise. So if you hear me mention the enterprise throughout my talk, I'm referring to all of our sites collectively. And then if you hear site specific, it's referring to either the health system or Arizona, Florida, Rochester. So when we look at the three different ways, we kind of break down our data and how it's shared, and I'll get into more specifics on our next slide as well. But the top level is really that executive or board level. And so we're talking about the Board of Governors, Board of Trustees, where they're getting quarterly reports, but a very limited amount of information, enough to keep them informed and be aware of overall performance, but without getting into the level of detail that we'll talk about once we get down to, say, leadership or work unit levels. The scorecards that they receive every quarter actually just have three main measures on them. Our overall patient experience for the particular site, patient safety, which is their PSI 90, and then our mortality. So you see that overall score for those three categories. And then they also include the scores for each site on HCAHPS, Leapfrog, US News, and the CMS overall star rating. Then if you go down to the next level for leadership, that's where we're talking more about, again, like those sites that we talked about. So Arizona, Florida, Rochester, the different health system sites would all have quarterly reports with additional details. And Mayo Clinic is committee driven, so we have lots of committees and lots of structures to work through. And that's also one of the challenges when it comes to sharing data, making sure we're getting it to the appropriate places at the appropriate level and the appropriate times. When we look at kind of our main leadership committees, every site has a clinical practice committee, hospital practice subcommittee, outpatient practice subcommittee, quality subcommittee, and patient safety subcommittee. So those are kind of the core groups that we want to make sure we're sharing data with on a regular basis. And then Mayo Clinic as a whole, so again, going back to that enterprise level, also has a Mayo Clinic CPC and so on down the line of committees, including a Mayo Clinic Quality Committee. So those quarterly reports are also standardized. So all of the committees are seeing the same information, but they include much more information than the Board of Governors, Board of Trustees level. So here we'll have those same metrics, but diving down deeper into, say, our CAUTI, CLABSI, C. diff, our fall rates, pressure injuries, more detail around patient experience, where there's a question for both hospital, outpatient, and ED included. So you're getting the ability to drill down and learn a little bit more about your specific site, as well as that roll up when you look at all together collectively. We also do the external benchmarking for those same 4 that I mentioned and under the executive level. But then we can dive a little deeper into that site performance. So if we are seeing a trend positively or negatively, and we want to go back and see what's driving that, we can dig into detail, which also goes, I'll talk about in a minute too, in terms of real-time data. We all know probably that the external benchmarking that we have in those organizations is data from previous time periods, sometimes quite a bit lagging, sometimes a little more recent, but it's not the current state. And so managing those messages with leaders so they understand that, and when new scores or reports are released, that's not necessarily how we're performing today, but having that data ready and how we are performing currently. So when we get those questions or we need to be aware of the trends, we're ready and we have that information. And so we can compare our current present day performance against how we were scored in a report that comes out. We share, like I mentioned, at all the committee meetings. We have regular cadences set up depending on the meeting and type of information, but for sure a quarterly basis at a minimum. And then we have dashboard access. And I'll show on the next slide all of the various dashboards that we have that allow anyone at Mayo to go in and dig deeper into any of the different quality or patient safety measures. And then being able to customize your view, whether you want to see that, again, overall roll-up, or you want to see all the way down to a site or a unit specific information. And that segues into the final category with the work unit level information. So those same dashboards that can be used at that roll-up level can get down further, so you can see how you're performing within your work unit. We can also run specific reports, especially when it comes to patient safety data. So the information that goes in our patient safety system that I'll talk about in the next slide as well has all the additional details and information available, and supervisors and managers can request additional access and reports to get more out of there than you would find on a dashboard. And then 2 of our recent, over the past 2 to 3 years, we've put a lot of effort into expanding the use of electronic visual management boards, and then the whole tiered huddle concept. So over the past, like I said, probably 3 years, we've been in the process of rolling out huddles at all sites. So each site has its own sequence, tier that they go through in the morning. And then by late morning, we have an enterprise-wide huddle where you get the quality and safety leaders from across the entire enterprise, where we're sharing that higher level quality and safety information, anything that's happened in the last 24 hours. The work unit huddles are more specific. You get into more of the day-to-day information, specifics about if there was a patient safety event, other issue that came up on the unit that needed to be addressed. So as you go up each tier, the information that's shared gets up to a higher level. To go hand in hand with that, we now have the electronic visual management boards that just this past year, late 2025, we've gotten implemented at all of our hospital units across, again, the enterprise. So every single site has them. They are kind of like the traditional old-fashioned paper, except obviously much easier to use. You've got the electronic feeds. Staff can interact with them off of their cell phones. It can be used both for the fun and the team building, sharing pictures of pets or vacations or whatever, but also what are the key quality and safety priorities for the unit, where there are concerns. You can use Post-its in terms of questions and answers. So both of those tools I'll reference over the next few slides as well in terms of how we have been incorporating our safety data into those processes. So we can go to the next slide. All right, and I know this is too tiny to really see. It was more of the effect of it and to kind of share the scale of what we have available in terms of dashboards. So this is what we call our dashboard of dashboards. And at Mayo, within our quality department, we have a team called Quality Data and Analytics, and they are the ones that help us out by getting this amazing data and putting it into the different dashboards and reports that we can then access. And so, like I mentioned in the previous slide, all of these are open to staff at Mayo Clinic, so you can go in and check these out. And then you can adjust, the views so that you're looking either at those roll-ups or there's more specific information. So you see along the top there, if you can read it, and I know it's tiny, when I referred to the different leadership reports, CPC is our clinical practice committee, you would see that information there. You would see it also broken down for the various external ratings and rankings. So you see Leapfrog, US News, etc. When you see patient safety in that second column over on the right-hand side there, that's the information that's coming out of our patient safety reporting system. And I'll talk in a little more detail about that in a second. And then you can also see the other components of patient safety that are called out on different dashboards, like caught eclampsia or hospital-acquired infections. So backtracking to patient safety reporting, we have a system that we switched to in the summer of 2022 and made some enhancements that really made it much easier for our staff to report. It's voluntary reporting. You can log through the EHR if you're in a patient chart and you have something you want to report, or you can go directly to the patient safety reporting tool without going through the EHR. If you have a concern that you want to report anonymously, we can do that through compliance. And we also occasionally will get a patient safety concern that will come through another avenue, such as a patient concern that's gone through our patient experience group, or a concern that might have gone to legal or risk, and then they bring to our attention. With the patient safety system, it walks you through pretty sequentially the type of event, what happened, contributing factors, as much as you know at the time, and builds on there as we go through the review process. But captures near misses, good catches, all the way up to serious harm. And the dashboards here can get to all that information. So the different event types, the harm levels, the volumes that we get. It doesn't get into any PHI. It doesn't get into the details of the events. But when I referenced earlier on the reports that you can get as a manager or supervisor, and of course, if you're involved in a particular review, then you get that information. But these dashboards keep it at that higher level in terms of the details that are shared. When we went to the easier system, we saw an increase, and we continue to see an increase every year. So our volumes of reports coming in are really, really high, which is great. It's also a challenge for the patient safety team to try to keep up with. But important that we're capturing that. And like I said, the majority of what we get is those near misses and good catches. And then just a fraction of those that turn out to be serious harm and going through the more comprehensive review process. What we are trying to do and in the process of doing is how do we utilize what we're learning through those good catches and near misses, and so we can be more proactive and making sure we implement and build on those, and not just responding to the serious harm ones. In terms of utilizing technology, I think most of us are in similar places now with AI and the agents and everything that are out there and available, and how can we use that within our patient safety data and use it to help us comb through, look for patterns, look for trends, look for other things that we may or may not be seeing if we do it through the manual process. So all of that is a work in progress as we speak. We can go to the next slide. And then in terms of how do we use the data, so there's a lot of data, and I know I've got questions popping up that hopefully we can get to at the end. I did see that most recent one about fatigue and dashboards, and that of course is a possibility when you have that much information and data available, which is one of the reasons we've tried to streamline the reports that go to certain committees so that you don't get directed to this wall of dashboards and try to figure out what you need. So trying to streamline it and decide what is it that leaders need to see at what level, so it doesn't become noise or it doesn't become overwhelming. But good question. So in terms of what we do with all of this information, kind of a good segue. Looking at patient event trends and responses is important. And when we do things like our culture of safety survey, continue to get feedback that even though we're trying, there's always room for improvement on this as well. But when I talked about those huddles and those visual management boards, that's given us another opportunity to share that we didn't have before, and also seems to be potentially contributing to a stronger culture of safety, but also an increase in those reports that are coming through. As more and more staff see how they're used, see that it's not a punitive process, it's a learning process, we can continue to share that information through those venues. It also makes communicating back easier when we have had a review or an event go through a process, so we can help close the loop. In addition to the huddles and the boards, though, we also provide emails back to those that have reported as it goes through, once they submit, once it's been kind of triaged and determined on what next steps are, and then after the event is closed. If you were a reviewer or a participant in the event, you would also be receiving communications as you go through that process as well. And obviously that information is much more specific than what we share when we share broadly. And I would have to say that continues to be a challenge, and it probably is for a lot of you as well, when it comes to sharing patient safety information, on sharing enough to be transparent and helpful and learn from it, while also protecting the patients and the team members that were involved. So, how do we share our learnings in a way that aren't identifiable, but yet we're showing, where have we found gaps? What are we doing to close those gaps? What are the follow-up actions? So always kind of something we're aware of and continuing to work on as we refine it. Quality improvement projects are big at Mayo, and these can be small, within a work unit, all the way to a bigger site and sometimes even enterprise-wide project. Again, all of that data that's out there, when we start to see trends or issues, or for seeing things pop up through the patient safety reporting system that we know need to be addressed, but it might be not specific to one event or one review that we go through. Quality improvement projects are a great tool and done frequently at Mayo, and very much supported in the culture. Local and enterprise-wide initiatives, again, finding that balance. Sometimes we do need a site or a unit, maybe even just to have the autonomy to implement something that works for them or that they've noticed as a need or something they want to respond to. But also sometimes it calls for an entire system-wide improvement. So sometimes that might be a device or a piece of equipment that's surfaced, and turns out we're using it across all sites. That's a much bigger response than maybe something that happened that's more localized to something that they're seeing within a work unit. Same with things like fall prevention and pressure injuries. We do have local groups that meet, but we also have enterprise-wide fall prevention and pressure and injury prevention groups that are looking at the things that actually would affect everybody in terms of policies, procedures, products, and our approach to those issues in general. And then lastly, strategic planning and priorities. So every site with Joint Commission has its own QAPI plan. And so there you see more of the detailed information. There you'll get where a site knows they have an issue with medication errors or something more specific that maybe not everyone has seen, but they have a trend in. So those more specifics would be found at QAPI plans and local plans. But then also bigger picture, when you look at Mayo Clinic as a whole, where are we sitting from a patient safety standpoint, a quality standpoint, and what does our focus need to be on when you look at it collectively? And so also driving some of those trends, and then the efforts that we see in the strategic plans that we go through every year. Right. That brings me to the end of my slides. I want to make sure I leave Chip adequate time. So I will turn it over to Chip for his section, and then hopefully be able to answer some of the questions when we get to the end.
Hey, thank you, Kate. And congratulations to you and to Mayo for the amazing work that you're doing. And good afternoon to the rest of you. I'm really excited to be here with you for a little while this afternoon, and I appreciate that you prioritized, this opportunity in your day, to kind of join this discussion. When I was asked to present today and to share what it is that's allowed St. Luke's to be successful, in this space, I kind of made up my mind that I wanted to share some practical observations and examples from our experience using data to inform and improve performance. So I hope that I can give every one of you at least one takeaway about what it is that you can do to prevent harm, perhaps utilizing, a new novel idea. Because, what it really boils down to is the faster that we can see risk emerging, the faster that we can respond to it and prevent harm from actually reaching our patients. So before I get into my slides, just in case you're not familiar with St. Luke's University Health Network, we're a 14 hospital integrated health network located in northeastern Pennsylvania and western New Jersey. And I've had the privilege of spending my entire professional nursing career working here at St. Luke's. I know I'm sharing my camera and you can all kind of maybe, see my age a little bit. I was here for the transition from paper pencil to the implementation of electronic health record. I've seen a lot of technology enter, the healthcare space. And now I'm here as we're learning how to embrace and incorporate artificial intelligence to support high quality and safe patient care. So you can go to the next slide, please. I think all of these presentations kind of start off with a slide like this. Before I get into our data tools and reporting workflows, I wanted to make sure that we paused and kind of get grounded a little bit on some, on some of the fundamentals. In this case, I wanted to make sure we get grounded a little bit in culture, because none of that other stuff really matters if you don't have the right culture placed behind it. So I'm sure that this audience is already, largely on board with safety culture, or just culture. But this slide, I thought, captures the foundation of what we had to build here at St. Luke's before our movement towards real-time patient safety data could really make a difference. And honestly, it's not just about building the culture that was hard work. It's the effort and energy required every day to kind of continuously nurture that culture that really allows for the sustained success. So at the center of our culture is a fair and just, non-punitive environment. This is not just about saying, hey, we don't punish people. It's about consistently demonstrating that we're interested in learning from events and not assigning blame. When teams trust that reporting won't come back to hurt them, that's where the shift from a compliance-oriented behavior turns into a genuine curiosity and interest in learning. This is when we started to hear about the near misses and the subtle workflow breakdowns that never showed up in our retrospective data. Transparency is another big one. If you want real-time insights, you have to be willing to see reality in real time, even when it's uncomfortable. It's this openness that leads to accurate reporting, and accurate reporting is the raw material of your learning system. In our early days, we found people were reluctant to report because they were worried about the reaction or the response. Once we made transparency safe, the reporting became both richer and timelier. And finally, now we can get into this data-driven culture. We talk about this data-driven culture kind of like using a flashlight and not a hammer. We say we use data to shine a light on our system and process opportunities, not to beat individuals up that make mistakes. Using patient safety data in this manner requires a really deliberate mindset, and maybe in some situations, even a little bit of a shift away from investigations that focus on who done it. And it's time to ask the harder questions. What allowed this event to occur? Or what conditions made this outcome possible? As leaders, once we began framing our conversations around this kind of systems behavior instead of individual behavior, the adoption of real-time tools improved dramatically. Next slide. This slide is probably one of the strongest indicators that our safety culture has not only improved, but it's become functional and mature. What you see here is our patient safety event reporting rate over the last 19 years. The blue line represents all event reports submitted by staff through our voluntary reporting system. The red line shows the rate of our harm events over that same period. Here you notice a pretty consistent trend. Event reporting has increased dramatically, 180%, while harm rates have stayed low and stable. This is exactly what a healthy safety culture should produce. On the contrary, if reporting goes up and harm goes up, you have a quality problem. If reporting goes down and harm stays the same, you have a culture problem. However, when reporting goes up and harm stays flat or decreases, you have a learning system. Now, this didn't happen on accident, but rather this is the result of transparency, psychological safety, and a data-driven mindset. Next slide, please. In addition to voluntary reporting systems and culture, I wanted to make sure I highlighted another equally important dimension of the safety program. And for us, it's the active engagement of our medical staff. Voluntary reporting is absolutely essential, but it primarily captures, what is seen or experienced in the moment. To create a true, highly reliable system, we needed clinical experts reviewing their own work, identifying variation, and driving improvement based on professional standards. Our radiology department provides the perfect example for this. This slide summarizes our radiology peer review process. This was built around the ACR RAD peer program. This is gold standard methodology from the American College of Radiology. What's important here is that this workflow isn't dependent on someone voluntarily reporting a concern, but rather it's embedded directly into our radiologist workflow, so that thousands of studies are randomly reviewed every year, variances are detected systematically, and significant discrepancies go to a panel of radiologists for further deliberation. This process has ensured that every step is structured, it's consistent, and it's learning focused. For us, this is our medical staff bringing safety culture to life through professional accountability and continuous improvement. If you look at the table here, you see what engagement really looks like. Last year alone, over 67,000 studies were reviewed. Agreement rates remained extremely high, 98.4%. And most importantly, this level of rigorous peer review identified serious events early, issues that might not have been captured or certainly wouldn't have been captured timely in a voluntary workflow. So for me, this slide really underscores the value of clinicians genuinely engaging in their own quality, in their own quality work. In this example, our radiologists have truly embraced transparency and data sharing in support of a non-punitive learning environment. Throughout their daily work, each of them contribute to difficult case conferences and collaborate to improve image interpretation. Next slide. Here's another example of what happens when we leverage data with physician engagement and true interprofessional collaboration. This was a performance improvement project. It summarizes a PI project that was sponsored by our Diagnostic Excellence Committee. Severe acute pancreatitis is one of the most complex diagnoses we manage. These patients require intensive nursing, medicine, surgery, critical care, GI, and interventional radiology. And the outcomes depend heavily on how well these teams coordinate, especially in the early course of illness. Across our 14 hospital system, we were seeing predictable variation. We had different approaches. We had different escalation paths, different timing for imaging, fluids, and consults. And that variation was evident in our outcomes. We changed this by getting all of the disciplines and specialties, the physicians and the nurses together to standardize the essentials. Early fluid protocols, early imaging criteria, consult triggers, escalation pathways, and criteria for transfer to higher levels of care. Once we aligned on a shared approach and reinforced it with real-time feedback, the results followed. You can see it here in our data. Length of stay improved, readmissions have come down, and our mortality index dropped well below peer benchmarks. So this is an example of what is achievable when we combine real-time insights with engaged clinicians. Outcomes improve even in the most complex clinical conditions. Next slide, please. This is a pretty cool one. This is another area where real-time data has made a measurable impact in early detection of patient deterioration. Across all of our med-surg units, we have deployed Masimo Patient Safety Net technology. This is a system that captures continuous and high-frequency vital signs directly from the bedside. These real-time vitals, paired with laboratory data and other assessments captured in the EHR, feed directly into the DI, or the deterioration index, giving us a constantly updated AI-driven risk score for every patient. Instead of relying on episodic vital signs or waiting for a rapid response trigger, our nurses and providers now see deterioration risk as it's emerging, not afterwards. This slide shows how that capability has matured over the last couple of years. The integration of true real-time vitals into the DI through Patient Safety Net was a turning point, and it began the downward trend of codes per 1,000 discharges. We have subsequently added automated supervisor alerts. We've refined nurse advisory alerts. We've added the STAT RN responder to provide additional assessment and expertise. And we've improved provider workflows to increase the actionability of alarms and reduce fatigue. The result is seen here. A decline in inpatient codes across the system due to more consistent escalation, fewer surprises, and earlier intervention. What I'm not showing you on this slide are resuscitation to discharge rates that are consistently better than the national average, and a significant reduction in unplanned transfer rates from med-surg to critical care. Now, just in case that's not enough from a financial ROI perspective, this reduction in transfers to critical care has also had a $1.6 million positive financial impact over the past 2 years. That's $600,000 in direct savings related to general supplies and $1 million in added revenue due to the increased capacity in our critical care units. This example just goes to show what is possible when frontline teams have reliable, real-time safety data and the workflows to act on them. Deterioration becomes predictable rather than sudden, and preventable rather than inevitable. Next slide. This is another one that's pretty exciting, and it's another area where we've seen the true impact of real-time safety data here in our sepsis performance and our ability to consistently deliver evidence-based care according to the sepsis bundle. A few years ago, we implemented a cognitive computing model embedded in the EHR that continuously analyzes vitals, labs, trajectories, and clinical documentation to identify sepsis risk earlier than the traditional screening. This model complements, does not replace clinical judgment, but it does give our teams a meaningful head start. And you can see that reflected here in these two trends. The top graph shows the SEP1 bundle performance. For several quarters, performance was flat and hovering around 80%. I know, not too shabby, but it wasn't where we wanted to be. Once we integrated the cognitive model into workflows, partnered with hospital medicine, nursing, critical care, and ED teams on pathways, we saw a clear upward shift. More consistent early recognition led directly to higher bundle reliability. And the bottom graph shows sepsis mortality over the same period. And the direction is exactly what we're going to see. Over time, mortality has steadily declined as teams became more confident using real-time risk signals to escalate sooner, order labs earlier, and start treatment without delay. This is another example of how real-time insight plus engaged clinicians equals better outcomes. In addition to the deterioration index and sepsis model, we have also incorporated AI workflows to support antimicrobial stewardship, fall risk, readmission risk, as well as end of life. Next slide, please. And my last slide. So I just wanted to summarize a little bit in closing. It's these effective practices that have made all of these improvements possible for us, from pancreatitis to deterioration index to sepsis. It all comes back to these disciplines, things that we've learned to apply consistently across our entire system. First, we quantify and prioritize true opportunities. Not everything can be a tier 1 issue, and you can't solve everything all at once. My supervisor routinely reminds us, you can't boil the ocean. Data and real-time data help us focus our energies where it matters most. Second, we make sure that we are working from reliable data sources. Whether it's patient safety net vital signs, the DI score, or peer review findings, teams must trust the data, and it must be presented in a meaningful and actionable way. Third, we incorporate reporting into normal work. Nurses, physicians, technologists, everyone encounters and uses safety signals in the course of care, and we need ways to elicit their feedback efficiently instead of treating reporting like it's an extra task. Fourth, we continue to embrace transparency. If we want rapid learning, we have to be willing to see the truth quickly and share it openly. And finally, we rely on robust review processes. Honest, objective peer review at the service line and system levels, multidisciplinary root causes, a liberal use of root cause analysis, not just for sentinel events, but even those near miss events, using expert facilitators to get to the real root causes. And then closed loop communication back to senior leadership, and most importantly, back to staff. This combination of good data, real-time insight, clinician engagement, and reliable review has helped us create a system that doesn't just measure safety, but actively improves it. And that's the end of what I had prepared, and I'm going to turn it back over to Jade.
Thank you, Chip and Kate. This was amazing. I mean, so much good information. We did have quite a few questions, and so I'd like to start at the top of those and kind of work our way down. And if there are other questions that folks have, please just enter them in the chat. We'll do our level best to work through each and every one of them. But Kate, these first few were directed at you. The first from Eric: how do you monitor the implementation and effect of patient safety recommendations?
Yeah, thank you for the question. And I would say definitely a continued work in progress. You know, it's something that I think we've improved on over the years, but still recognize that we have further to go, especially if it helps, I should say, if it is tied to one of those priorities or an overall project, because those are structured in a way that we make sure we are you're taking it through the whole project framework, measuring, improve, and getting into a control phase. I think the challenge is more when we're looking at it in regard to like an isolated event or review, and we've made some recommendations as a patient safety team, and the handoff is to the clinical team to take it from there. I think in some of those instances, it doesn't always sustain, or we are unaware from a patient safety team standpoint on, if those changes continued. So opportunities around that, the bigger issue, the bigger efforts, the bigger projects, we have a better line of sight on and are able to monitor and make sure what we're putting in is effective. We also log the effectiveness of our solutions. So when we come up with things as a result of a review, score them based on how effective they are, strength of the solution. And we know, like, education and training reminders are the weaker end, engineering things out are the stronger end. So trying to capture that as well, so we can kind of monitor how many of those recommendations fall in the weak, intermediate, or strong category.
That's really fantastic. Chip, anything you'd like to add to this?
Yeah, actually, and Kate, I echo many of those things. I think I think part of the answer to this question lies in good project management as well. Identifying your measurables and deliverables up front. I think balancing outcomes measures, along with process measures. Like, for example, there was a lot of concern that our acute pancreatitis model, which involves shifting patients sometimes, to our tertiary centers, where advanced imaging is available. There was concern that some of that might overwhelm some of those centers. So measuring not just the outcomes that I shared or that I summarized in my slide, but also some of the process, measures that go along with those projects. And another that is close to me, very close to me right now, because I was working with a group, perioperative group, earlier today. I think being clear in your organization about what some of those high risk processes are. We all know what the pre-incision timeout is, but how many of us know if the pre-incision timeout or the fire risk assessment in our ORs is being conducted and performed of such a quality that it's actually capable of preventing an event from happening? So as much as all of us have been engaged in perioperative safety for 20 plus years at this point, you can't allow people to get complacent. You need to identify those high risk processes and put monitors around them.
Thank you both for those great answers. The next question is, would you be comfortable sharing the event reporting system that you currently and previously used?
Yes.
I'm happy to share, as long as there's no rules about me sharing, vendors. So I will tell you, so you can all laugh. The prior system we used was my paper pencil process. It wasn't until 2009. We were kind of late to the game. It wasn't until 2009 when we implemented the RL-Datix application called RL6. It's now called RL6 Risk. And similar to what Kate described at Mayo, we've also embedded it, if you will, within the Epic skin, or within the skin of our EHR, excuse me.
Yes. And I was going to say the same thing as Chip, as long as we are okay to share. But yes, Mayo had previously used Midas, and in 2022, we switched to Vigilance, which is now Inovalon, and then have also done, fairly heavy customization on our end internally. So
Great, thank you. The next question comes from Patricia. Is the closed loop communication to the reporter automated? Does it happen through the incident reporting system?
Yes, good question. Some of it is automated. So you get kind of that template email back, which we know isn't necessarily, it doesn't feel very personal on the person that is receiving it. As we reach out to reporters and reviewers, obviously we're trying to make the personal contact from that perspective as well. And then trying to get better about the closing the loop being more than just that template. So we have the automatic responses, but making sure, being aware that we're also adding that personal response as much as possible. I think where that gets challenging is we have so many near misses come in, which is wonderful. But those are more of the canned response and something that is on our radar for wanting to improve on going forward.
Great, thank you. We have just a few more time for a few more questions. The next one is safety event reporting. Does it include your ambulatory centers and private physician offices?
Yes.
Yes.
Great. That was the easy one. This next question is from Angela. It was originally directed to Chip. How is the AI deterioration intervention configured to capture or flag patients with abnormal vitals, labs, and imaging?
Oh, so you are asking a relatively non-technical guy a technical question, and I would be more than happy to help coordinate a conversation with some of the folks from our IT clinical team that owned that. So I can only respond to this at a very high level. But using our electronic health record and the messaging system that is part of that EHR, there is a bot that is continuously monitoring the real-time data that is fed into the EHR and is using the secure messaging platform to notify providers, including the nurses that are assigned to the care team of patients that are getting into trouble.
Great, thanks. Kate, anything else to add from your end on that?
No, nope.
Okay.
We
Yeah.
can go to the next one.
Yeah, and I think we'll take this as the last question. And the best that my take of this question is if you could talk a little bit, and I think Chip, you started down this path about how to have this culture of safety and to create a non-punitive culture where reporting is actually applauded.
So, and I could probably talk for a long time about this. So I'll try to be, I'll try to be concise. But I do think that part of it, and I want to just go back to one of the prior questions about providing feedback to people. One of my staff several years ago said, I want to start sending thank you cards to people for patient safety event reporting. And, at the time we're seeing about 12,000 reports a year. And I was like, yeah, good luck with that. And oh my gosh, does she not prove me wrong? She started this, 6 years ago, and she has, and now it's grown and we've formalized this, and there's a lot of support around it, but every individual that submits a patient safety event report every month, every unique reporter receives a thank you card from one of the patient safety officers acknowledging their commitment to reporting. We have taken these people and essentially deputized them. That's what I call them, the deputy patient safety officers. So that thank you card every month has a message embedded in it that reinforces some aspect of our culture. And we ask them as the deputy patient safety officers to be the ambassador of that message in their clinical space. So, I mean, you're hearing it from a guy that was skeptical initially that this was A, going to be meaningful, B, was going to work, and C, was going to be sustained. And my staff totally proved me wrong on all three. So I give that some thought. Give that some thought. For us, it's relatively inexpensive, and it's been real meaningful. But now back to the question about how do you start building the culture? I will tell you, and we did it backwards before we realized that we were doing it wrong. You got to get the senior leaders on board first. And I don't want to embarrass anybody on my team. I love we have great senior leaders here at St. Luke's. But I had 4 senior leaders, and I asked and I asked 4 different senior leaders, what did it mean to be accountable in a non-punitive culture? I didn't consistently get the same answer. And if I went to our managers and asked them that same question, I didn't ever get the same consistent answer. And if I'm being transparent with all of you, I don't know that I could have consistently articulated an answer to that question. So you've got to answer that question first. What does it mean to be accountable in our non-punitive culture? And that was a partnership between patient safety, risk management, and human resources. And once we answered that question, and we got our senior leaders to all agree and align on that, we now train and teach that as part of our orientation to all of our staff.
That's great. Thank you very, very much. I'm just in the interest of time. I know we could have talked about that for the rest of the afternoon with great results. One more slide, please, Melissa. This will conclude the end of our webinar for today. Next slide, please. But we do have an upcoming webinar that I hope that you'll be able to join, where we're going to delve further into culture, leadership, and governance with leaders from these high-performing healthcare systems. That will be Tuesday, June 9th from 3 to 4 p.m. Eastern Time. Pre-registration is required and is available now. So if you have not already, please go to the National Action Alliance website under webinars and register. We will make the recording and these slides available, and just thank you for all of the work that you do on behalf of patients and our healthcare workforce every day. Enjoy the remainder of Patient Safety Awareness Week. Thanks all.